I'm going to go ahead and get started here. So I'm Dan Johansen. For those of you who don't know me out in the fishbowl, I'm the third joints fellow. I'm doing a database study. Jeff, Brenna, and Dr. Gilland allow me to be part of this year. It's titled Risk Factors for Prosthetic Joint Infections Following Hip Arthroplasty for Femoral Neck Fracture. So as we know, hip fractures are a major cause of significant morbidity and mortality. In the United States, hip fractures account for 260 to 300,000 admissions per year. Looking at these graphs on the right, you can see that over time, the incidence of hip fractures have remained pretty steady. But as our population is getting larger, the elderly population gets larger, so we're expecting hip fracture incidence to increase as well. So by 2040, we're expecting more than 500,000 admissions for hip fractures. And about half of these are due to femoral neck fractures. So the treatment of femoral neck fractures is debatable, but thankfully this department held a debate, which I think settled that debate. I took the liberty of drafting this consensus statement for you all. Hemi or total hip arthroplasty is recommended for all femoral neck fractures. In summary, arthroplasty is key. Not quite. As we know, there's internal fixation or arthroplasty options for femoral neck fractures. And it depends based on the fracture characteristics as well as patient characteristics, which I think that debate went into great detail about. It was an excellent debate. And although we like to think arthroplasty is the best surgery in orthopedics, it's not without complications. This paper from 2019, I think, kind of summarizes the differences between arthroplasty for elective osteoarthritis compared to femoral neck fractures. Not all hip arthroplasties are created equal. When looking at complications after arthroplasty for femoral neck fractures, there's higher readmission rates, there's longer length of stay, the patients are more likely to discharge to SNPs, and there's also higher complication rates compared to elective arthroplasty, with the three most common being dislocation, infection, and periprosthetic fracture. So when talking about infection, we know that prosthetic joint infection is a disastrous complication and truly life-changing for the patient. We see pictures like this every week here at the U, and we know that it's a result of cause of significant morbidity for the patient and a large cost for our healthcare system. In the United States, we spend about $1 billion every year for PJI care alone. And just as we expect hip fractures to increase, we expect infections to increase as arthroplasties go on more frequently. So by 2030, we expect to spend about $1.85 billion every year. And in the literature, the rate of infection after arthroplasty for femoral neck fracture has been cited anywhere between 2 to 7%. So that's much higher than the infection rate for elective hip arthroplasty. So I think for all these reasons, I think the study is important. Trying to understand infection, what causes infection, what are the risk factors, and the attempt to try to reduce infections is important. What this study is doing is trying to understand the risk factors for PJI after hip arthroplasty in the setting of femoral neck fracture. And I think it's important because there's a large amount of data out there regarding risk factors for PJI for elective hip arthroplasty. But overall, there's a relative paucity of evidence for complications and infections related to femoral neck fractures. And so if we can identify possible modifiable risk factors in the perioperative setting, we can potentially reduce these risks. Additionally, if we can identify high-risk patients, potentially we can make some changes in their intraoperative care or postoperative care that might reduce their infection risk. So the way we went about this study was by using the Arthroplasty for Hip Fracture Consortium data. This is a multi-center consortium which was established in around 2020. It includes 9 academic centers. The University of Utah is one of the participating centers. The remaining 8 are listed here. And it's a database that's maintained by Dr. Kellam at the University of Missouri. Essentially, it started to gather data, try to get more numbers for hip fractures, and try to figure out if we can look at more outcomes and look at more complications, and again, try to improve outcomes after those surgeries. So using this database, we looked at patients that suffered femoral neck fractures between 2010 and 2021. We retrospectively reviewed their charts and identified those that developed PJI versus those that did not. We included hemi arthroplasty and total hip arthroplasty, and all patients had at least 1 year follow-up. For exclusions, we excluded conversions of prior internal fixation, and we excluded revision arthroplasty. We looked at a wide range of variables, including various patient demographics such as sex, ASA, tobacco use, and several comorbidities, the kind of usual cast of characters for infections such as diabetes, heart disease, CKD, liver disease, and a few others. And for perioperative factors, we looked at a host of them as well, including whether or not there was a hemi or total place, the anesthetic type, the surgical approach, different kind of intraoperative factors, such as antibiotic use, wound lavage, and then also postoperative factors, such as whether or not they developed a medical complication or their disposition to where they went after discharge. We also want to look at fracture characteristics. Would a Garden 1 or 2 have a lower risk than a Garden 3 or 4? Would a higher mechanism of injury fracture have a higher risk than a lower mechanism of injury? So once we gather all this data, we perform the following analyses. These are performed by Brenna, who's in our department. So for our results, we included 1,277 patients in this study. We identified 43 PJIs for an infection rate of 3.4%, which again is consistent with the previous report in the literature. In this group, a little over half had hemiarthroplasty placed compared to 46% for totals. About 2/3 of the patients were females, and that kind of makes sense as more females are more prone to having hip fractures than males. And the top 3 most common comorbidities are hypertension, hypothyroidism, and diabetes. Regarding ASA class, about 75% of the patients were either ASA 3 or ASA 4. So again, not a healthy group of patients, but again, that's expected with their fragility fracture population. For demographics for our results, we saw a higher proportion of PJI in the hemiarthroplasty group compared to the total group. There were 67% of the PJIs were hemis, but again, there was no significant difference for this result. We did, however, find a significant difference for ASA class, where we found that an ASA 3 or 4 has a higher risk than an ASA 1 or 2. And interestingly, 97% of PGIs in this cohort are either ASA 3 or ASA 4. There was no difference between sex. This graph here shows the various comorbidities that we looked into. And it shows a proportion of patients that had PJI with each comorbidity. So if you're looking at the hypertension bars in the middle, or in the second one there, you can see that out of the 43 patients that had PJI, about a little over 80% of them had hypertension. When looking at them individually, diabetes, hypertension, liver disease, and COPD were all risk factors for PJI in this group. And probably as expected, there weren't any differences noted between the fracture characteristics, so no difference between Garden class, no difference between high energy or low energy fractures. This slide here is showing the perioperative factors that we looked at, with the table on the right showing all the significant factors that we identified. So those were intraoperative blood transfusion, hemovac drain use, the administration of general anesthesia, discharge to SNF, and also development of a post-op PE. And interestingly, looking at this data, we found that about half of the PJI patients had a drain placed, suggesting that we probably shouldn't be putting drains in these patients. A high proportion of patients that received, in the entire group, received general anesthesia, and a high proportion also were discharged to SNF. So that makes sense that a higher proportion of these patients were the ones that developed PJI as well. There was no difference in infection rates between the surgical approach, which I thought was interesting. And then once we had these results, we went ahead and performed a hazard ratio adjustment calculation. After adjusting for sex, ASA, diabetes, and liver disease, the only remaining statistically significant factor was disposition to SNF. And it had a 2-fold increased rate of infection compared to those that are discharged at home. So the study is not without limitation. Obviously, it's a retrospective study. It's a database study. So it's prone to selection bias. It's prone to misclassification bias. Also, I think we probably underreported our infection rate here for 2 reasons, at least. By only having a 1-year follow-up, obviously we know infections can occur after 1 year. And also, just the nature of these patients, we know that mortality rates after hip fracture are 20% or higher in this group. So if they died before getting their infection, if they're prone to one, we'd be missing that and underreporting that as well. So in conclusion, this study identified a 3.4% infection rate in patients undergoing arthroplasty for the treatment of femoral neck fracture. And we found that PJI in this group is associated with general anesthesia use, ASA class 3 or 4, various comorbidities such as diabetes, hypertension, liver disease, and COPD, the intraoperative blood transfusion administration, the use of a hemovac drain, development of a post-op PE, discharge to SNF, and I think very important and interesting point here is that SNF remained a risk factor after adjustment for some of those comorbidities such as sex, ASA, diabetes, and liver disease. And with these results in mind, I think it's a start at least to try to go out and do more research and try to figure out ways to parse out some of these details and try to reduce infection in this population. I just want to give a big thanks to Jeff Franson, Brendan Blackburn, and Dr. Gilman for helping me out with this project and allowing me to present these results today. So thank you.
Yeah. The question on the SNF factors is brought up a lot, and I always wonder if you modify or in how many people it's modifiable. Right. It doesn't suggest that, because I know your service versus like the trauma service, I think we patients may be different.
Yeah, I don't know that that's the case. So we actually are looking at this right now from this data. We did this first, and now we did a subsequent study. We're looking at SNF versus home health, and we tried to control for like certain patients. You're probably right. Like if they're demented 90-year-old, they're not going to send them home unless they came from a home environment and they have good coverage there and good health, and I'll still send them home. So we tried to control that. We took all those patients out of the study, and we just looked at patients under 80 who weren't demented and had a recent stroke, and as a way to sort of control for some of those variables, and looked at the discharge disposition. And they were slightly different groups in terms of ASA, but they're still fairly similar groups, fairly unhealthy populations. And it was SNF discharge was like the only independent risk factor that we found. It was basically like a odds ratio of 4 for infection. And I do think that it is modifiable in a lot of people. More modifiable.
That's the interesting part is what do we need to do to change that?
What I've found is like for these patients is I like the medicine service gets them, I operate on them, and I take them from the medicine service and say, hey, I'd love for you guys to co-manage, but I'm gonna control the rest of it from here once they've had surgery. And then it's like they get PT like they have a total hip, they get treated like they have a total hip, they get their word fracture hits taken off their stuff, and then the disposition gets total hip. And then they get managed by medicine if they have any medical comorbidities while they're in the hospital. And the game changes, I feel like. If they stay on the medicine service, they go to medicine floor, they get, sometimes improper PT. And then the disposition is always 100% SNF. In fact, I had a medical doctor tell me, like, no, you can't send them home. It's like against the rules. They have to go to a SNF. And I was like, well, guess what? Like the rules have changed. And now they're on my service. And you get to manage their medical problems.
I just wonder how different. I think it'll be interesting to how different patient. I don't know what you are class. That's more.
But if they were living at home before, could they potentially go back home? I mean, it's just a
maybe. It depends. Right. They're living at home before and selling it.
Sure. Something to consider, though. I mean, it's the one thing.
It seems unmodifiable. Like drains, I'm not certain that that's true.
Yeah, surgery and blood loss, and like complexity of surgery, all that kind of stuff. Right? The rest isn't. Nice job.
Thanks.
All right, keep it moving. My name is Nancy Campbell. I'm one of the Peds Ortho Fellows. And my project for the year was neuromonitoring can be safely stopped 20 minutes after pediatric spine deformity correction, the 20-minute rule. And my faculty advisor and principal investigator is Dr. John Smith. So a little bit of background, neurologic compromise during pediatric spine surgery is among the greatest concerns and feared complications among patients, their families, and surgeons alike. While the risk of spinal cord injury during pediatric spine deformity surgery is estimated to be less than 1%, it's a devastating and life-changing event when it does happen. Neurologic events can occur at any time, but they are most commonly related to deformity correction. The goal of neuromonitoring is to identify neurologic injury early, allowing the surgical team to perform interventions that eliminate or minimize postoperative sequelae and complications. As a result, neuromonitoring is now the standard of care in pediatric spine deformity surgery. Prior to modern day neuromonitoring, the Stegner wake-up test was used to detect intraoperative neurologic deficits. This was described in 1973 by Dr. Stegner. It involves reversing the anesthetic, waking the patient up, and then asking them to perform and comply with an exam on the table in the operating room. This is still considered the gold standard today, but as you can imagine, it's difficult to perform, it's difficult to interpret, and it's not without significant risks involved. Since that time, we've come a long way, and monitoring of the spinal cord has significantly improved. We're now able to perform somatosensory monitoring and motor monitoring in real time and to map it down to a specific location in the spinal cord. So today in the OR, motor potentials and sensory potentials are performed simultaneously, but changes in sensory potentials lag behind those in motor potentials when there's a complication. In a true neurologic event, motors are typically lost first, followed by a loss of sensory potentials. And the amount of time between the two kind of varies in the literature, but typically it's within 20 minutes, you'll see that loss. While neuromonitoring is universally agreed to be beneficial, the length of time to monitor after correction is highly controversial. Due to the lag time in the loss of sensory potentials behind motor potentials, Primary Children's has adopted a 20-minute rule, whereby monitoring is continued for 20 minutes after correction. If no changes have occurred during that 20-minute window, we discontinue neuromonitoring at that point. Our hypothesis for the project was that stopping neuromonitoring 20 minutes after deformity correction is safe and does not result in undetected neurologic events. So why does it matter? An increasing level of importance, there's cost, there's anesthetic concerns, and then the efforts towards standardization in spine deformity surgery. So primarily is cost. First up is cost from just using the operating room per minute, and then neuromonitoring itself, which is billed typically in 15-minute increments. Neuromonitoring is exquisitely sensitive to anesthesia. Inhaled anesthetics affect both motor and sensory potentials by decreasing signal amplitude and increasing signal latency, rendering them significantly less useful in the operating room. As a result, monitoring requires use of TIVA or total IV anesthesia. In the pediatric population, TIVA has been associated with prolonged extubation and prolonged wake-up times, as well as just a less reliable recovery. So our practice here at Primary Children's, we monitor for 20 minutes. At the 20-minute mark, we stop monitoring, and we tell the anesthesia team at that point they can turn off the IV anesthetic and turn on the gas if that's what they choose to do, and we leave it up to the provider. And third and most important is standardization. All pediatric spine deformity surgeons are using monitoring during cases, but there's significant controversy regarding how long to monitor for after correction. Efforts have been made to define optimal care and standardize pediatric spine deformity surgery in other areas of pre, intra, and postoperative management, but this has not been done in the duration of neuromonitoring. This is an excerpt from a study that was published by SRS in 2020, in which they polled adult and pediatric spine deformity surgeons, and they had 205 responders. Question 11 was, during which procedures do they use neuromonitoring? And as you can see here, over 90% responded that they use monitoring during AIS, kyphosis, and congenital scoliosis. And the following question really highlights the controversy that exists. When do you discontinue monitoring? The numbers don't agree much at all. So 45% discontinue a half hour after correction or until the wound is closed. 29% discontinue 1 hour after correction or until the wound is closed. A little over 12% discontinue when final tightening is performed, and then a little over 12% discontinue when the anesthetic is discontinued. So we have a lot of room to grow to reach agreement on this topic. So for this study, the neuromonitoring database of all pediatric spine deformity cases performed at PCH between 2013 and 2022 were retrospectively reviewed. We looked at neurologic events and the timing of them in relation to deformity correction. And we also looked at our patients to see who woke up with a deficit that was not caught in the operating room. There were 1,516 pediatric spine deformity cases. Patients were aged 9 months to 24 years. There were 90 neuromonitoring alerts that occurred post-correction in that 20-minute window. Of those, 15 patients were idiopathic scoliosis, 32 were neuromuscular scoliosis, and 43 were kyphoscoliosis cases. All of those events occurred before or within 20 minutes after correction. There was one patient who did not have any change in signals during the case, but then had a loss of motor and sensation 8 hours later. This was thought to be due to a syrinx that was not detected preoperatively. So overall, based on this data, our rate of detection of neurologic events within the 20-minute window was over 99%. So just to kind of sum this up, neurologic injury after pediatric spine deformity surgery is rare, but it's life-changing for everybody involved. The goal of monitoring is to detect intraoperative changes in real time in the spinal cord and allow the team the chance to reverse or minimize post-op deficits. And based off our data, we believe that discontinuing neuromonitoring 20 minutes after correction is safe, it's efficient, and it doesn't result in missed neurologic events. So we actually put together an abstract that was recently accepted, and it's going to be a podium presentation at SRS this year. We're currently drafting a manuscript to submit to Spine Deformity Journal. These are my references. Any questions?
That was a well done study. Thank you.
Thank you.
Don't have my volume on? Sure, that's okay. Oh, how do I? Stop sharing. We'll figure this out eventually. Okay. For those of you who don't know me, probably a few of you, I'm Patrick. I'm one of the joint fellows, and oh, you guys don't want to see that? Anyone know how to fix that one?
Once you start it, there's a swap displays button at the top.
Well, mine's also presenter view on my screen.
Then move your cursor over to the other side. The swap displays, that third one over.
Use slideshow. There you go.
There we go. Okay. All right. Thank you, Dr. Johnson.
New fellowship, you finally figured out.
I knew how to put the computer on. I just don't know how to run the PowerPoint. So I'm going to be talking about stairs affect post-op recovery after total joint arthroplasty. And I'd like to thank Dr. Gill and Dr. Anderson for their mentorship during this project. Here are our disclosures. I clearly have none. The Total joint arthroplasty is one of the most common procedures done in surgery. There's over 1 million total knees and total hips done every year. And one of the most common questions we get asked in clinic are, I have stairs in my home, and I don't know if I should go home after surgery, and is that going to affect it, or should I just go to a rehab facility because I don't think I'm going to be able to manage being at home after surgery. And as Dr. Gillen talked earlier, we know that patients do better if they go home. And so while we get asked that question a bunch, we have no literature to support when we report back to them saying, no, stairs don't affect you, you should go home. It's much better for you to recover in your own home. But we really are kind of a baseless in telling patients whether that's true or not. We have a general sense of it based on the post-op recovery and PT that we do, but we really have no evidence to support that. And it's a big concern for patients and a driver of them asking to go to rehab facilities if they have stairs at home. So the My Mobility study was a study performed by the Zimmer Biomet company that was a prospective cohort study that looked at patients that were aged 18 and over. They were undergoing either an isolated total knee or total hip arthroplasty without any other arthroplasty planned within the year. And what patients did is they agreed to wear a watch and have their functional outcomes recorded by Zimmer Biomet. If they agreed to wear the Apple Watch throughout their recovery process throughout the year, then they were allowed to sign up for the study, and they were given an Apple Watch to help with that. So when patients agreed to sign up for the study, a large amount of demographic data, including their preoperative function and preoperative ambulatory status, as well as a large amount of data about their home dwelling was obtained. And then patients were given an Apple Watch to wear post-operatively for up to a year. And then these functional outcomes from the Apple Watch were used, as well as patient-reported outcomes are obtained at certain defined time points of 1 month, 3 months, 6 months, and 12 months. And the idea of this was to trial out a mobile application-based recovery therapy that Zimmer Biomet was trying to use and create called My Mobility. But what it created was a database of functional recovery that was quite vast. And so we had a research meeting after a clinic in which we had been pestered with this question of do stairs matter? And we decided that we were going to look at this and say, do stairs really affect the outcome of patients undergoing primary isolated total knee or total hip arthroplasty, in order to give our patients a kind of definitive answer in clinic, so that we weren't up there kind of baselessly claiming they can go home without any data behind that. So what we did was a secondary analysis of this prospectively created and collected database, and group patients by the procedure that they underwent, either total knee or total hip arthroplasty, as well as whether they did or did not have stairs at home. And then we analyzed the groups based on their functional and patient-reported outcomes. And these outcomes, again, were defined by the study pre-op or post-hoc, because they were at 1, 3, 6, and 12 months. We did not define those. That was kind of what they had in the database. And then for statistics, we did generalized estimating equations with an unstructured correlation matrix to evaluate patient-reported outcomes and physical activity metrics, and then a post-estimation analysis were used to compare scores and metrics between time points. Hopefully Brenda's here to answer any questions on that one. So for results, there were 4,127 total patients included in the study. There was 1,926 patients in the total hip group and 2,201 patients in the total knee group. Regarding the two groups between hip and knee, there was no clinically significant difference between the groups. An average age of 62 in the hip and 64 in the knee. BMIs were between 28 and 30. And the hip group was about 50-50 male and female. There was more females in the knee group than in the hip group. And then breaking down further into those patients that had stairs and no stairs in each separate arthroplasty, there was no clinically significant difference between the stairs group and the no stairs group and the total hip or the total knee group. And so what we looked at, steps per day is probably the most easily obtained from the Apple Watch and most reliable. And it showed no difference between the total hip groups of patients that had total hips with stairs or without stairs, and total knee group that had stairs or no stairs. We didn't analyze between the groups because the recovery of a total knee, as most people know, in the 1 to 3 month recovery process is quite different. And so it's comparing apples and oranges. But between the two groups, in each surgical procedure, there was no difference. For gait speed, there was also no difference between the total hip groups, the total hip group with stairs and no stairs, and total knee, except at 6 months, there was a statistically significant difference with the total hip groups, and patients with stairs had a slightly faster gait speed at 6 months than those that didn't, but we could debate the clinical significance of that. Walking asymmetry was the same. There was no significant difference between patients with stairs and without stairs for differences in percent walking asymmetry. As far as functional outcomes, we obtained the ED5Q. There was no significant difference between either group. And then there was a Hoots Jr. and a Coos Jr., which are hip and knee specific outcome, patient-reported outcome measures that showed no difference between any time point between those patients with stairs and those patients that didn't have stairs at home. So limitations, this study is relying on patients wearing their Apple Watch at home for a year. Certainly, you could question whether everyone was wearing the watch at all times and the reliability of that. However, there are studies that do show the reliability of these wrist watches that whether it's Fitbit or Apple Watch, or there's a bunch of them out there that do show reliability of not only the measurements that you're getting, but patients wearing them. Patients were receiving therapy as part of the study. Everyone received the mobile application-based recovery process, and so that could bias the study in towards all people got better at the same rate because they were getting physical therapy like recommendations at home. And we didn't control for the number of steps, number of flights of stairs. It was a binary outcome of whether you had stairs or not. So maybe there is a difference between if you have 2 flights of stairs or not, but we didn't control for that. So in conclusions, patients do improve objectively as well as subjectively after total hip and knee arthroplasty. And it doesn't appear that stairs have any effect on the outcome. So I think we're okay telling patients in the clinic preoperatively that it's okay to have stairs at home. You can go home. And your recovery will be just as fine as for those patients that didn't have stairs. I'd like to really thank Brenna for this. She's the hard worker of the Arthroplasty Research Service, and she helped out a bunch with this and does a lot of the legwork, and so this couldn't have been done without her. And I'd also like to thank the entire department for allowing me to stick around for so long and putting up with me. All of you guys have affected my life and career, so I don't know if I have another opportunity, so thank you guys all for having me.